Now we would move west again to the western part of North Carolina, to Buncombe County and the BCMS Project Access. And we have with us George Bond and Alan McKenzie.
Good morning. We're from Buncombe County, North Carolina, a community of about 200,000 folks, with about half living in our metropolitan city of Asheville. We're the tertiary care center of all of western North Carolina. We're the home of nephrologists, oncologists, neonatologists, and others. We just opened a new heart tower, and open heart surgery is now becoming rather routine in Asheville. We're the place where everyone in western North Carolina comes for health care. In short, we look like the medical land of plenty, right? Well, that's what we thought until 1994, when we did an extensive study in our community and learned that over 15,000 of our citizens lacked access to basic primary care, low income, and could not afford health insurance. We had a handful of struggling free clinics and a local health center trying to provide that care, but they did not have access to specialty care, nor could they provide pharmaceuticals to their patients. My own public health department, when I arrived 3 years ago, was the major provider of indigent health care, but we were sadly inefficient, and new patients had to wait 3 to 4 months to receive an appointment. In fact, the emergency room was the major source of indigent care in our community for thousands of our folks, and our county commissioners were literally dumping thousands and $600,000s of dollars into the emergency room black hole, like many other commissioners across this land trying to pay for indigent care. In short, we had a crisis in health care on our hands. We wanted a comprehensive system of health care for our indigent, but what we had was a fragmented, episodic, sick care non-system. So we all agreed, our county commissioners, our medical society, our hospitals, we've got to do better, and we've got to find our own solution right here in Asheville. We had no new resources, so we realized we had to work with the materials at hand. So what did we have? We had a county commissioner group that had $600,000 they were ready to put immediately into indigent care. We had an active medical society with a staff ready to go to work. We had a handful of free clinics and a public health center, 3 community-minded hospitals, and over 500 physicians, all wanting to do their part, but afraid of being overwhelmed if they took the very first referral from either the health center or one of the 3 clinics. From these basic ingredients, Project Access was born. It is a public-private cooperative effort between Buncombe County government and the Buncombe County Medical Society. County government redirected its $600,000 away from emergency care into the Buncombe County Medical Society, and that has become the ongoing financial support for administration and pharmaceuticals for our enrolled patients. The Medical Society enrolled 500 of our 600 physicians to join Project Access, and each physician has pledged to see usually 30 uninsured patients through Project Access with absolutely no expectation of reimbursement. Our county commissioners led efforts to increase by 60% the capacity of my department to provide primary care, and appointment waiting times went from 4 months to 3 or 4 days. Our commissioners also provided seed funding to 4 other indigent care facilities to build their primary care capacity. All 3 hospitals agreed to absorb the cost of x-ray, laboratory, and inpatient care, and every pharmacy in our community agreed to discount their drug cost and dispensing fees for Project Access. The result is a seamless system of comprehensive care to the indigent population. Founded on the $600,000 of county commissioner money, operated by the Buncombe County Medical Society for general administration, physician recruitment, and patient referral. It is supported by every major player in our community, with 85% of our practicing physicians, all 3 local hospitals, every single pharmacy in Buncombe County, all 4 free clinics, and the Buncombe County Health Center, and the Department of Social Services that has outposted workers to help enroll folks into Project Access. It is heavily used by our medically indigent population who now, through our public-private cooperative effort, receive primary care. It is not episodic, but rather comprehensive, from primary care through inpatient hospital care, including laboratory services and full access to prescription drugs. Well, what has Project Access accomplished? You remember that 15,000. Well, now 13,000 of that number receive comprehensive primary care, and every single patient last year needing specialty care or hospital care received it. I said every one. $3.5 million of virtually unrestricted free care has now been leveraged with that small contribution by our county commissioners. And lastly, over 500 of our physicians were able to demonstrate their concern for humanity in an organized program that spread the burden of indigent care across the entire provider population. 30 years ago, not 10 blocks from this site, Dr. Martin Luther King gave his famous "I Have a Dream" speech. Well, folks, we have a dream in our community in western North Carolina. We have a dream that one day every person, every man, every woman, every child when asked the question, do you have access to a doctor, will be able to answer yes. Project Access is making that dream a reality. Thank you.
Please, Dr. Ridings and then Louise.
But if I didn't, just from that presentation, it would be the kind of community that I think all of us would feel very good about. I hope you will take that word back.
Thank you.
North Carolina has a Good Samaritan law, which I would assume aids this process enormously. In terms of replication, what is the situation as you understand it in other localities, and the impact of having a law like that on the books in that locality would make on the opportunities for replication?
Create a sense of confidence and comfort among our healthcare professionals in seeing this patient population. However, and I was actually involved with writing and getting that passed. I'm pleased that you recognize that. It was a great accomplishment for us. However, the physicians in our community all have their health malpractice insurance coverage, and the patients that they see through this program are actually, in the care that they provide, if there was a malpractice suit, would be covered by that policy.
Louise?
Again, on the question of replication, how replicable is this program in an area that does not have as many resources in the medical field?
Well, we thought the key ingredients to our program really were some basic funding by our county commissioners, and that can be generally found in the community. You need a mechanism for the medical society, for the doctors to do the good and wonderful things they all want to do, but haven't found a way to put the rubber to the road, and that is a medical society or a PPO or some type of other organization. And you need a community that's willing to come together and recognize the need. We think that exists just about anywhere. But having recognized your question is very real in rural North Carolina. We have many communities with 2, 3, or 4 physicians, and it's going to take some pulling together by those groups. 2 or 3 physicians can't make this a reality. We are looking to expand our program, however, outside of Buncombe County. We're in the process of talking to communities just around us, and so they can build off our experience, and we'll be happy to do that with others.
David Osmond.
Your target population is people who have incomes at or below 200% of the federal poverty level. I assume there are some people with incomes above that who don't have health insurance. Do you know what percent of the population in the county now has access to health care because of this, the overall percentage?
The short answer, no, I haven't got a direct count of those over 200% of poverty who need health care and don't have it. Our assumption is that we were looking for the low-income population that didn't have health insurance. There are many folks, doctors, wives, and children, who don't need or choose not to have health insurance, and we didn't see that as our target population. In fact, 200% is fairly generous. That's right at the third quartile of income, between second and third quartiles. That's almost half the population.
Bill Klinger and then Lee Shore.
The program obviously requires a high degree of volunteerism to make it work, and I gather that the Good Samaritan law has something to do with that. But how do you maintain that ongoing sense of volunteerism, which I think is so obviously very essential to the success of this program?
I think one of the main things that bodes well for the sustainability of this program is the recognition that the physicians and the healthcare community is obtaining as charitable and caring about their patients, and recognizing that is the reward that our physicians receive. And I don't think that they would ever give that up at this point.
There further is some, and I don't want to dwell on it, self-serving aspect of this. Our physicians, if they don't take care of the problem in the community in a primary care setting one way or the other, they're going to see those patients in unassigned care at the emergency room or at night. And also our hospital. In fact, their cost for Project Access patients has gone down by almost, how much, Alan? $750,000 since we started this. So while they took a hit, they lost their $600,000 in the emergency room right up front. We reinvested that at the front end of the system, and now they're saving more than we ever put in the emergency room.
Lee.
I'm curious about how your program is perceived by the people, the patients and their families who benefit from it. Because when 30 years ago we passed Medicare and Medicaid, the assumption was that for patients it was really there were many disadvantages to being the beneficiaries of charity, and therefore we tried to increase the number of people who would be enrolled in some form of insurance, public or private. What is your perception about how patients feel about being dependent on the charity of the doctors and the institutions in your county?
I can comment on that. We receive hundreds, thousands actually, of thank you notes from patients expressing their appreciation for the care that they received. And that's very rewarding for us, but I think that it shows that the way that they're treated through this healthcare system does not create a stigma. They are treated as if they have gold or platinum health insurance by all of the healthcare providers. So they don't sense that they're receiving charity. It's not given in that way. And secondly, one of the rewarding things is the number of patients that contact us and ask us how they can give something back. They volunteer in our free clinics, and they contribute in other ways.
Ellen McKenzie and George Bond, thank you both very much. Tuberculosis, a patient review approach, and Paula Fujiwara and Rosemarie Riley are here. Rosemarie?
Good morning. I'm Rose.
Review approach, and Paula Fujiwara. Tuberculosis, a patient review approach, and Paula Fujiwara and Rosemarie Riley are here. Rosemarie. Much.
Things is the number of patients that contact us and ask us how they can give something back. They volunteer in our free clinics, and they